And we are at the top of the hour, so without further ado, I would like to introduce our speaker today. Joining us, we're grateful to have Dr. Lauren Borges. She's a clinical research psychologist for the Rocky Mountain MIREC for veteran suicide prevention. And Dr. Borges, are you ready for me to turn it over to you?
Yes, I am. Thank you. All right.
We see your screen.
Excellent. That practice paid off. So hi, everyone. I'm Lauren Borges. I'm an investigator at the Rocky Mountain MIREC, and I thought it might be helpful to just give a little bit more context about who I am, since most of you probably aren't familiar with me. So prior to working here, I was kind of first exposed to psychotherapy in the context of a dialectical behavior therapy clinic, where I became really interested in how people respond to moral emotions like guilt and shame, and then pursued graduate training in a pretty behavioral context at Western Michigan University, where I got training in evidence-based psychotherapies for PTSD at the Battle Creek VA Medical Center. I worked on their PTSD residential program for about 3 years. It is for sure a hidden gem if there are any trainees on the line. It's a great training program. And then I completed my internship at the VA Maryland Healthcare System, University of Maryland School of Medicine as a trauma intern, where I received more training in ACT and evidence-based psychotherapies for PTSD, and finally completed fellowship here at the Rocky Mountain MIREC, where I focused my efforts on this line of research on ACT for moral injury. So I'm incredibly excited to be here today and to share a little bit about my work group's model of moral injury and our intervention. All right, so none of this work would be possible without my very extensive and important team. Sean Barnes is a co-PI on a grant that we recently received funding for, this VA Rehabilitation Research and Development Merit Award, and also support from the Rocky Mountain MIREC. Jake Farnsworth, Robin Walzer, and Kent Drescher have been really instrumental in developing the manual of ACT for moral injury alongside me, so also incredibly important collaborators. Of course, this talk does not necessarily represent the views of the VA, and I have no conflicts of interest to report. So we'll turn it over to the poll questions now.
Thank you so much. So for our attendees, as you can see on your screen, you do have a poll question up, so I would like you to go ahead and let us know what is your primary role related to mental health care. If you can go ahead and select all that apply. Just go ahead and click the square or circle right next to your response. And looks like the answers are coming in, so we'll give people some time to check these out. So again, we'd like to get an idea, what is your primary role related to mental health care? And you can select all that apply. The answer options are consumer, student, trainee, or fellow, clinician, researcher, administrator, manager, or policymaker. Looks like about 60% of our attendees have replied so far, so I'm going to give people a few more seconds. Okay, I'm going to go ahead and close this out and share those results. So as you can see on your screen, 8% of respondents selected consumer, 8% selected student, trainee, or fellow, 71% selected clinician, 19% selected researcher, and 7% administrator, manager, or policymaker. Dr. Borges, did you have any comments on this before I move on to the next poll?
No, I'm glad a bunch of clinicians are joining us today. I hope this is very relevant for them.
Excellent. So I'll go ahead and clear that and move on to the next one. This one's pretty cut or dry. Do you work within the Department of Veterans Affairs? Yes or no? Go ahead and select your option there. Surprisingly, answers are a little bit slower coming in for this one. So for our attendees, just go ahead and click the circle right next to your response, yes or no. Do you work for the Department of Veterans Affairs? And it looks like about half of our audience has replied so far. We'll give people a little more time. All right, see a pretty clear trend. So I'm going to go ahead and close this out and share those results. It looks like 87% do work for the Department of Veterans Affairs and 13% selected no. So thank you. And would you like to move on right to the next one?
Yes.
So we would like to get an idea of how familiar are you with acceptance and commitment therapy. And we appreciate you taking the time to respond to these polls. It will help better inform Dr. Borges as she goes through her presentation. So please select one. You've never heard of it, you have heard of it, you've read about it, you've been trained in it, or you use it. So take just a moment and let us know how familiar are you with acceptance and commitment therapy. Okay, pardon me, just over half of our attendees have responded, but the answers are still coming in, so I'm going to give people a few more seconds. Okay, I'm going to go ahead and close this one out and share those results. 8% have never heard of it, 23% have heard of it, 35% have read about it, 14% have been trained in it, and 19% of our respondents use it. And did you have any commentary before I move on to this?
No, it sounds like a nice spread.
So just a few more poll questions for you. How familiar, I'm sorry, am I supposed to go through all of them at once, or did we have a break in it?
No, this is great.
Okay. How familiar are you with moral injury? Again, never heard of it, you've read about it, or you treated it. I got on a roll there, so I didn't know if I was supposed to stop. Go ahead and select the response right there on the screen. Okay, and the answers are coming in. So this is specific to moral injury. Have you heard of it? Have you read about it? Have you treated it? Have you not heard of it? Okay, I'm going to close that out, share those results. 9% of respondents have not heard of it, 23% have, 39% have read about it, and 29% have treated it. So thank you again. And I believe we have, here we go. If you have treated moral injury, which treatments do you most often use? And Lauren, did you want to talk through this one a bit more?
Yeah, so I should say I only had 5 options, and there certainly would be a couple other treatments that are relevant, but elected to just include these based on the parameters of the poll, only having 5 options for responses.
Thank you. So again, for our attendees, you can go ahead and select all that apply. So you can click on cognitive processing therapy, prolonged exposure therapy, adaptive disclosure, impact of killing, acceptance and commitment therapy for moral injury, or you can select a combination of any or all of the above. And it looks like people are a little bit slower to reply to this one, and that's fine. I'll give you a few more seconds. All right, so I'm going to go ahead and close this one out and share those results. An overwhelming 71% selected cognitive processing therapy, 21% prolonged exposure, 18% adaptive disclosure, 11% impact of killing, and 21% acceptance and commitment therapy for moral injury. And do we have one more to get through?
Yeah, one more question.
All right. There we go. So if you have used PE or CPT to treat moral injury, how satisfied are you with using these interventions for moral injury? Completely dissatisfied, somewhat dissatisfied, neutral, somewhat satisfied, or completely satisfied? Go ahead and select your response, and this will wrap up the poll question portion of the presentation. So again, if you've used PE or CPT to treat moral injury, how satisfied are you with using these interventions for moral injury? Okay, I see a pretty clear trend. I'm going to close this out and share these results. 1% selected completely dissatisfied, 24% somewhat dissatisfied, 26% neutral, 45% somewhat satisfied, and 4% completely satisfied. So thank you again to our respondents. It's very helpful. And with that, Dr. Borges, I'm going to turn it back over to you.
Great. All right. Well, thank you again for taking the time to go through those poll questions, so I have a sense of, yeah, your familiarity with moral injury, your familiarity with ACT, and your treatment experiences. I think that's really helpful. So today I'm going to do things a little bit out of order based on how I typically do talks. First, I wanted to spend some time talking about our group's conceptual model of moral injury so that we're all on the same page related to that. This will absolutely not be an exhaustive review of all the different conceptual models of moral injury. There are certainly a few, and if you're interested in learning about other models, I'd be happy to talk with you about those later. You can certainly email me after this. Then I'll spend a little bit of time talking about the relevance of moral injury to suicide prevention and kind of how that's been established in the literature. Moving from that, we'll talk about our development of acceptance and commitment therapy for moral injury, and I'll share the results of a case study that I think really nicely demonstrate an application of ACT-MI for a service member experiencing really significant moral injury and suicidal ideation and behavior. And finally, I'll share a little bit of information with you about a grant-funded study that I referenced earlier that we recently initiated, just a bit about the design of that. So let's move into our conceptual model of moral injury. So I like this image in thinking about moral emotions like guilt and shame. There's kind of a tension in this image. We need each other to survive, and with that comes an incredible amount of pain when we have done something to transgress against our social groups. I think it's important to consider the evolutionary roots of moral emotions like guilt and shame. We evolved language in these emotions for the purposes of working together to survive, and there's really evidence for this based on how our brains and neuroregulatory systems have developed too, and I think this is really important to consider in thinking about our model, that these emotions and experiences are critical for engaging in pro-social behavior and for our survival as a species. So here are some theoretical constructs that I think are useful when considering our definition of moral injury, which I'll get into next. So our theoretical model of moral injury is based on both social functionalism, a philosophy that supports the social purposes of moral emotions. Jake Farnsworth has a great paper about that I've referenced if you'd like to read more about it, and evolutionary science. So if you think about it, moral emotions, like I kind of alluded to earlier, can be really understood as coordinated and efficient responses that facilitate organism survival. Emotions like guilt and shame, we have them available to us because of the evolutionary functions that they've served, and I think this model is really important in thinking about how our team, our group, approaches moral emotions in treatment. And so on the level of kind of the species, moral emotions are available to us based on evolution, but on the level of the individual, we have this kind of range of moral emotions available to us, and then we select and construct our own environments based on the functions our behaviors serve in our internal and external world. So if we think about a moral emotion like shame and kind of my own history with that emotion, let's say that I'm experiencing tremendous shame prior to thinking about suicide. So then I think about suicide and learn that thinking about suicide temporarily removes me from the pain I'm feeling, and might even allow me to feel a sense of control or hope. So that makes it much more likely, given the function of that suicidal thinking, to kind of take me away from my moral pain. Makes it much more likely that in the future I'm going to engage in suicidal thinking in contexts where I'm experiencing moral pain. So functional contextualism really is a way of predicting and influencing behavior based on the functions these experiences serve and the context in which they're elicited. So those two kind of predominant theories really frame and drive our model, and I think are really critical in thinking about a treatment approach. It's really our aim to embrace the evolutionary and social functions of moral emotions so that we can help individuals develop new behavioral repertoires, new patterns in response to contexts that elicit these emotions so that they can break free from suffering. So first I'm going to present a slide that gets at some definitions, so we all have a common working model, and then I'll present a few slides which I like a little better that get at this visually. So first, when I'm going to be referring a lot to morally injurious events today, and when I do that, really I'm just talking about situations that occur that, you know, violate my personal values, my moral code, either by the actions of myself or by the actions of other people. And I think a really important point here, and this has been really kind of recently delineated in the literature, the reason for separating morally injurious events from the construct of moral injury is just like with PTSD. Exposure to a morally injurious event does not necessitate the development of moral injury. In fact, most people exposed to morally injurious events do not go on to develop moral injury. So I think it's really important to kind of separate those constructs. Moral pain follows from a morally injurious event, and evolutionarily it should follow from that. If you've done something that's a violation of your moral values, you should feel guilt, shame, contempt, anger, disgust. We'll talk a little bit more about what that looks like in a second. And finally, moral injury really is the suffering that we experience related to those contexts that elicit moral pain. So if we think about social, psychological, and spiritual suffering stemming from our attempts to avoid contact with our pain, this often means avoiding all facets of life that we consider vital and important, right? So I'm not going to engage in relationships if engaging in those relationships means that I'm confronted with these really painful emotions. I'm not going to engage in spirituality if that means that if that's a context for me experiencing those emotions, because that's really painful. And over time, what happens is our veterans, our service members' lives become narrower and narrower and narrower in response to these avoidance strategies. And I think these images should elicit this in a different way. So these are just examples of different kinds of morally injurious events. So this image depicts, you have a moral offense, so something I did or experienced where I violated my own values or someone else did, my own moral values. And that, like I said earlier, should elicit moral pain. Some examples of this that we often see, I'll be sharing a case study about a veteran who, or service member, excuse me, who he engaged in using intelligence to take the lives of people that in some ways he befriended. So that was incredibly painful for him. My kind of first work in moral injury in the context of actually cognitive processing therapy was with a veteran who witnessed an atrocity and was told that he couldn't intervene, which was an incredibly haunting experience. Certainly there's been a lot of research by people like Shira McGinn on the impact of killing, the impact of taking the life of another person, particularly the impact of taking the lives of children. So these are just some examples of the kinds of moral offenses that can elicit moral pain. And so this is kind of taking apart moral pain a little bit more, and I realize that this probably looks overly reductionistic, but this is to some extent what we do in psychotherapy as well, kind of taking apart this, excuse me, construct so that we can really see what it's made of, and then speaking to it more complexly as we kind of go through treatment. So some of the basic moral emotions that we experience as humans are shame, disgust, contempt, anger, guilt, and then our behavioral urges, our action urges in relation to those emotions are often to isolate, hide, disengage from them. We experience really intense self-blame related thoughts related to those experiences, like I'm a monster, all humans are evil, and a really intense gut, often physiological response where our stomach's flipping, we might feel tightness in our chest. And those experiences, we're wired to feel those experiences. It actually, because we feel that way, means that we have a healthy, kind of intact social moral system. But the problem is that our natural instinct is to avoid those experiences, right? So we become stuck in this pattern of pushing these things away to feel temporary relief, but that results in really long-term suffering. And that long-term suffering is what we characterize as moral injury. We do this kind of creative hopelessness exercise that I'll talk about a little bit later, with regard to the case study, where we have everyone in our group, Jake and I have everyone kind of add up all the things that they've tried, right, to manage this moral pain, everything that they've done, how workable that's been, and the number of years of suffering that that's caused, and that tends to be decades and decades of suffering within the context of a psychotherapy group, which is really a profound thing. So we try, you know, everything that we know to manage these experiences, and yet that trying to manage these experiences in and of itself might be the problem. And so this often results in disengaging from self-care, like I alluded to with relationships, discontinuing spiritual practice, and certainly suicidal ideation, behavior, substance use, and other kind of difficulties in functioning. Oops, sorry. So now I'll present a bit. I don't want to spend a ton of time on this, but definitely let me know after this if you have questions about this, on the background of moral injury and the relevance of moral injury to suicide prevention. So why is moral injury relevant? So recent kind of studies show, recent epidemiological studies show that exposure to morally injurious events isn't necessarily like the most common thing, but it happens for a fair number of our service members. Those who identify morally transgressive events, like I acted in ways that violated my moral code or values, transgressions by others, like I'm troubled by having witnessed others' immoral acts, and betrayal, feeling betrayed by leaders who I once trusted. That WISCO study used the morally injurious events scale to get at just those prevalence rates of exposure to morally injurious events in a military population. And I'll spend a little bit more talking about the relevance of PTSD and suicidal ideation and behavior, but it's kind of been increasingly demonstrated that exposure to morally injurious events is a risk factor for kind of a transdiagnostic host of psychological difficulties. And certainly you'll see most of the dates on these studies are pretty recent, so this is an area where more research needs to be done and is being done. When we think about moral injury and PTSD, moral injury and PTSD have been identified as related but distinct constructs. Certainly, there's some research that shows, in this Jordan study I'm referencing, the relationship between betrayal-based, potentially morally injurious events and PTSD is mediated by anger, whereas there's some evidence supporting the relationship between perpetration-based morally injurious events and PTSD being mediated by guilt and shame. And Craig Bryan published an article recently that kind of demonstrated some similar findings, where he characterized PTSD as uniquely associated with startle reflex, memory loss, self-reported flashbacks, whereas moral injury was uniquely associated and characterized by guilt, shame, anhedonia, and social isolation. And this certainly isn't to say that these two things can't co-occur at the same time, but I think it's important in thinking about treatment approaches to kind of understand which factors, which processes are responsible for the development and maintenance of PTSD versus the development and maintenance of moral injury. And for some, it might be experiencing both simultaneously. We recently wrapped up a qualitative study that I'll be submitting for publication soon, where we recruited 14 veterans based on a lifetime history of moral injury. So not necessarily current moral injury at all, but had to endure some lifetime difficulties in functioning related to exposure to morally injurious events. And all of these veterans completed kind of our gold standard in the VA, either 8 or more sessions of cognitive processing therapy or prolonged exposure. And 12 of them identified persistent difficulties in functioning related to moral injury, which, again, this is a qualitative study and a very small sample. We cannot generalize the results of this, but I think it speaks to this idea that potentially sometimes evidence-based psychotherapies for PTSD, there might be some residual symptoms or experiences remaining related to moral injury. I think the majority of veterans struggling with moral injury receive treatment for PTSD. That makes perfect sense because those treatments are rolled out. However, the efficacy of these interventions for moral injury specifically is still unknown. So now let's kind of establish the sort of basis of the literature for moral injury and suicidal ideation and behavior. So all of you on this call, I'm sure know that suicide, intervening on suicide really is VA's top priority. 20 veterans die by suicide each day. We know that exposure to morally injurious events is a risk factor for suicidal ideation and behavior. We also know that the self-directed moral injury, so that moral injury that we tend to see more associated with kind of guilt and shame and those experiences, and suicidal ideation, the relationship between those constructs is strengthened at higher levels of self-judgment. Killing has been uniquely associated with suicidal ideation, and it's possible that EBPs for PTSD may not always sufficiently target the pathways maintaining suffering and moral injury, which could cause suicidal ideation and behavior to persist. So we need treatments that really take an upstream approach to intervening on suicidal ideation and behavior that target moral injury and these experiences of suicide simultaneously. And so certainly acceptance and commitment therapy for moral injury is not the only player out there as far as where the field's moving with different psychotherapies. So adaptive disclosure has been established, and research is underway with a multi-site study. The same is true for impactive killing, trauma-informed guilt reduction. I know Sonia Norman will be giving a talk later this week on moral injury. And then we've got our intervention, and I think related to evidence-based psychotherapies for PTSD, there certainly have been case studies published using prolonged exposure and cognitive processing therapy that have been shown to treat difficulties associated with moral injury. But RCTs have yet to be published that demonstrate the efficacy of these interventions for moral injury. So I think that's just important to hold in mind. So now that we've kind of established the scope a little bit of what it is we're talking about and why it's important, I'd like to spend some time talking about our protocol development. So this slide, I think, nicely illustrates sort of the existing barriers of other interventions and maybe and the need for an intervention like acceptance and commitment therapy in targeting content related to moral injury. So, you know, I think this is an empirical question, the idea that extant interventions may not adequately target moral emotions like guilt, shame, and contempt. I would argue that those interventions weren't necessarily developed explicitly to target emotions like guilt, shame, and contempt. So we need an intervention grounded in a theory that was developed explicitly to target these experiences. There are several potential symptom pathways that can lead to moral injury, and frankly, we need to know a lot more about this. This is an area of research for sure. So we've proposed a transdiagnostic intervention that will target things like responding to moral pain and suicidal ideation and behavior simultaneously, because responding to moral pain might be suicidal ideation and behavior might be a strategy to responding to moral pain. We also need interventions that are recovery-oriented. A lot of existing interventions focus on symptom reduction, so reduction of moral injury symptoms, which is not our goal of our intervention. Our goal is to kind of move with your values in the presence of moral pain, to move towards engaging with your life while experiencing emotions like guilt, shame, contempt, disgust, and anger. And related to this issue, I think one area of research that's certainly being undertaken right now, I think Brett Litz is kind of leading the way on this, is defining the boundaries associated with the moral injury construct. So we're still kind of unsure about that, and you know, if this should be a diagnosis, I don't advocate for that necessarily, but that's I think an area that is that's being kind of investigated right now. I think the other piece of this is thinking about reducing symptoms. We don't have great measures of this either. So like thinking about measuring emotions like guilt and shame, it really requires, as veteran, a person's ability to be able to kind of observe and describe those experiences within themselves, sometimes to fill out a paper and pencil measure that's pertinent to that. So I think it's important that we think creatively about like measures of functioning that actually get at behavior. And I know that's something that our team is working on. I think another piece of this is that individual treatment modalities might limit opportunities for social interaction. So we've elected to develop Acts for Moral Injury as a group-based intervention so that we kind of have optimal opportunity to evoke moral emotions given the social context that these experiences occur in. So a group intervention will give us much more opportunity potentially to elicit some of these experiences than an individual intervention might, given that these emotions really serve social functions. So here's a little bit just about the history of ACT for Moral Injury. So first, this intervention was developed as a 6-session group in the PTSD residential program at the Palo Alto VA. Then it was implemented at the Denver VA and grew to be a 12-session intervention. We piloted, Jake Farnsworth and I piloted the ACT-MI group for 2 years in this format. And finally, we're on step 4 of this right now. We have received funding for a randomized controlled acceptability and feasibility pilot study where we'll complete 6 groups of 12-session ACT-MI and 6 groups of 12-session present-centered therapy to kind of understand the acceptability and feasibility of both of these interventions. So this won't be an efficacy trial just yet because we're still working to revise, refine, and really hone in on core processes associated with our manual. So as far as why, I know we've talked a lot about what ACT is. I want to spend a little more time with why ACT is a good fit for moral injury. So this is the Hexaflex that you may or may not be begrudgingly familiar with, potentially, depending on your level of interest in ACT. And you'll notice these processes kind of can all be elicited simultaneously. These aren't independent. We'll be talking about them independently. So really the goal of our intervention is to open up to moral pain, to open up to these thoughts, to these stories you tell yourself, to these painful emotions that you're experiencing, and to cultivate a willingness to engage in those feelings for what they are rather than what your mind is saying they are. And that what they are rather than what your mind is saying they are piece is diffusion, being able to see the experiences as they are. Acceptance is really about that willingness. So that's kind of that open pillar, being open to these experiences in the present moment. So now moving to awareness, really the only place that we have any control over our behavior is in the here and now. We can't kind of rewrite the past or completely control the future. So the only place we really can engage with our moral pain is right here, right now. So cultivating willingness to actually be in the present is a big part of ACT for Moral Injury. Another piece I think that sometimes for people new to ACT can be a little bit aversive to engage with is self as context, and it's because it gets a little heady. But really what we're talking about with self as context is just being able to look at stories that you have about yourself and about other people rather than being stuck inside of these stories. Because when you're outside of these experiences looking at them for what they are, you actually have some ability to change how you're relating to them. And we spend a whole lot of treatment focused on kind of what are my stories about myself related to the morally injurious events that I've engaged in or that happened to me, and how do I kind of hold these stories for what they are and move towards my values, this engagement pillar. How do I understand what my values are? How do I clarify my values so that I can know what's important to me right now? How do I try on different areas of importance and engage in a really committed, meaningful way with those values? So the committed action piece is all about kind of small, defined, bold moves that individuals engage in, and this is a huge part of our treatment. This is something that we're practicing explicitly, and we have a skills practice between sessions every week, because really I would boil this whole intervention down to moving towards your values with pain, because these values that I haven't engaged in for years and years and years and years, I haven't engaged in them because of the pain that they elicit. And I think this image really kind of illustrates this nicely. So the goal of our intervention isn't reducing symptoms of moral injury. It's moral healing, and this is kind of how we've operationalized it. So moral healing means moving towards what I care about, so moving towards these values, moving towards spirituality while experiencing the pain that I have that comes with them, because in our values there's pain, and because we have this pain means that we must care about something related to it. So I think this is a really important kind of aspect of our intervention and something that we work really hard to instill. So I thought it might be nice to use a case study that I recently wrapped up to illustrate our protocol under development, because we still are developing ACT for Moral Injury. It didn't make sense to me to share our protocol with you just yet, since it's still very much is something that we are exploring. And after 2 iterations of both ACT for Moral Injury and present-centered therapy, we will be revising our protocol that was written into our grant. So let's kind of talk about an application of ACT for Moral Injury that I think fits nicely. So all of this is de-identified, certainly to protect the service member's confidentiality. He also consented to using this information in presentations and publication. And I think just right off the bat, so there are differences between this application of Act for Moral Injury and our protocol that we're working on for the grant. This was an individual application of ACT-MI via the VA's iPad Video Connect program, which was a super cool opportunity for me to get to kind of see how our intervention could work in a telehealth context. And I'm pretty stoked about these results. I think the other piece of this that's really cool, so our MIREC, some of you guys might be familiar with, has a cool suicide prevention consultation program. So this service member had just completed cognitive processing therapy and was referred to our suicide prevention consultation program, and it was determined that the factors driving his suicide risk were his avoidance of moral pain, his avoidance of guilt and shame related to the morally injurious event, and he used kind of suicidal ideation and behavior to really regulate his shame and guilt, so he didn't have to experience those emotions. So based on that, we were able to, I think, really nicely engage in veteran-centered care with this individual and develop a really idiographic approach to his treatment. So this service member was deployed in Afghanistan from 2008 to 2009 as a human intelligence collector. He scored a 66 out of 80 points on the MIQM, which is a measure of exposure to morally injurious events, Joe Currier's measure. He identified that the event that kind of most significantly affected his functioning was befriending members of terrorist organizations and using the intelligence he collected to take the lives of men, women, and children. And I think one thing I'd just like to highlight about that is it really kind of nicely illustrates the complex social situations that our service members face, right? Like, so I'm, at war with these people. I'm supposed to have a certain set of beliefs and assumptions about these people, and yet I have to befriend them as part of my job. And so now I have all these complex emotions related to that, and then I have to kind of engage opposite that and use this information to take the lives of these individuals. So I think that kind of sets the stage for how we can have these discrepancies in my moral values and my behavior that take place in war. He was in his early 30s. He was married with 2 young daughters, and his family was still practicing religion that he didn't identify with, but that created a lot of tension for him. I think a really kind of notable part of our work together, he had a friend who attempted suicide and became paralyzed as a result midway through our course of treatment together. He had another friend, kind of completely unrelated, who passed away, not related to suicide, but still incredibly traumatic, and a younger guy during the course of our work together. So within this 12-session protocol, he faced a lot of moral pain. Really, the goal for him for treatment was to take the mask off. It's a lot easier to put on the mask to hide than it is to look at yourself and try to get better. And so this illustrates kind of what we did, what ACT-MI was all about. And really, if you think about kind of standard ACT versus ACT for moral injury, and ACT for moral injury, we're focused explicitly on cultivating flexibility related to moral pain and engaging values that you might avoid because of that moral pain. So sessions 1 and 2 were really about figuring out what it is that he stood for now. That's often hard for people to identify when they haven't engaged with a number of their values in years and years and years. So we, use some measures to kind of determine the discrepancy between the importance of his values and his behavior related to his values. We engaged in a values card sort, which is kind of a cool experiential exercise that illustrates what might be most meaningful to you. And then he engaged in a lot of trying on different values and trying bold moves related to different values that we'll talk about later. His goal for treatment was to reconcile his actions with his values. I already referenced the creative hopelessness work that we do, which is kind of identifying all the strategies you've tried to control your pain that haven't really been workable to getting you where you want to be. For him, those tended to look like overworking, some of that like over-controlled behavior, suicidal ideation and behavior for sure, and just really significant isolation from relationships, from disengaging from taking care of himself, all of that. So sessions 3 through 5 were about kind of the limits of control and contacting the present moment, because really the only thing that we can manage is the here and now. So to illustrate the limitations of control, I'm sure some of you guys are familiar with the tug of war exercise from standard act. So within that exercise, we ask veterans to engage in a tug of war against a monster, and that monster is representative of their moral injury. So for him, he labeled the monster as the sergeant, really who he was in war. And so we have them kind of imagine that they're fighting, that they're in this tug of war fighting this monster. And in our group, we actually do the exercise experientially. Because this was via telehealth, we did this as an imaginal exercise. So you're fighting the monster, you're fighting the monster, you're fighting the monster, and in the context of this, he said, I can see the sergeant, but I can't see me, which I think was really indicative of some of his struggle. And he noticed urges to either become the sergeant or abandon the sergeant, identifying that in either scenario, part of him would die. So urges to either kind of become this thing or kind of avoid this thing completely. And obviously both of those strategies hadn't worked for him. So we spent some time talking, well, what are alternatives to continuing to engage in this struggle? And really, what are the costs to engaging in this struggle? As he's in the tug of war, he noticed, like, my back is to my values, right? I'm not able to see the things I care most about when I'm caught up in this struggle. I can't see anything outside of it. All I can see is the monster, and it's consuming me. So eventually we got to a place of practicing dropping the rope, right? Walking away from the struggle, noticing that it's there, noticing that you're going to get handed ropes all the time in life. Your mind's going to try and kind of trick you into engaging in this tug of war with your moral pain, and that ultimately doesn't bring you closer to where you want to be. So that kind of sets the stage for what are the alternatives. And one of the primary alternatives is acceptance, is this idea that can I have these experiences without them completely defining me? He generated this beautiful measure that then, poor guy, I then ran with that for the rest of our work together, of ballroom dancing with his moral pain. He used to be a ballroom dancer, and so we practiced really watching, noticing, observing, holding his moral pain lightly, while moving towards his values, which really is a dance, right? And he identified so we start off with really observing kind of basic moral pain, basic pieces of it, basic pieces of moral emotions, moral thoughts, moral urges, moral sensations that kind of come with those. And then we move towards talking about what our mind does with that, and how our mind takes a feeling like shame and runs with it and creates a story about it, wraps up language around it, generates all this whole kind of narrative. So we practice then kind of diffusing from noticing and holding our stories that we have about our pain and about ourselves, and that's that self as context work I was alluding to earlier. In the presence of this, he started to engage with the value of spirituality for the first time. He actually spontaneously identified engaging with spirituality, he said, but redefined it. So this wasn't about engaging with his historical religious tradition. This was getting a sense of spiritual fulfillment through helping others, and him calling that spirituality, which I thought was really beautiful. During this time, he really had the realization and kind of stepping outside of his stories about himself so that he could move towards his values. I don't think the pain will ever go away, and I'm not sure I want it to. I can mourn the losses I've experienced without lessening my own worth. Sessions 10 through 12 really focus on kind of holding stories about yourself and about others lightly for the sake of your values that might look to some of you like self and other compassion. This was probably the most profound thing a client has ever said to me. So we engaged in the tug of war exercise again, but this time I had him imagine that he's watching himself in the tug of war against the sergeant. So he's watching this experience. What would you say to yourself? Like, if you could, like, what would you say to yourself battling the sergeant? What would you do? And now, like, turning your attention to you, and of course this is a longer exercise than what I'm describing right now, turning your attention to you, what are you experiencing as you're noticing, watching yourself in the tug of war, as you're noticing kind of watching yourself play out the story, right? And he said, my heart is breaking, my body wants to shut down. You have to accept who you are, which includes who you have been. You have to be able to accept these stories as what they are, which means accepting different versions of you. So this is what we did throughout our work together. So weekly experiential exercises, as you would expect in ACT, weekly bold moves practice. Particular for this veteran, it included kind of redefining spirituality, engaging in emotional self-care, so actually spending time and resources on himself, which was huge, and that really resulted in a shift in the way he related to his pain. Oftentimes, if there are values that are being avoided, we want to ask, like, well, why? And it could be also because veterans generate like really rigid verbal rules about what it means to engage in those values. So that's where the redefining piece can come into play. And he really improved his relationships too with his family in just being more present, showing up for them. We also had different weekly skills practice that was meant to kind of map on to whatever the new skill was that was being taught this week. The safety plan we worked to update with Act for Moral Injury skills regularly throughout treatment, just given that his suicidal ideation definitely spiked after his friend attempted suicide. So we worked with that together, and this was cool. His wife was very interested in being involved in a post-treatment feedback session, which we did via telehealth, and his vet center provider was had a Bold Moves worksheet kind of printed out and ready to go for his first session after working with me, which I think is a beautiful example of really other providers working together to facilitate skills generalization, which is really the whole goal. So this is a picture of our Bold Moves tracking sheet, which we have people engage in every session. So what bold moves did you practice on this day? What values were they connected to? And what did you notice related to that? And I think this is really important because it illustrates the connection between values and pain. When you're moving towards this, you're going to feel this, and vice versa. And I think that nicely kind of contributes to this idea that this isn't about getting rid of these things. If we could do that for you, we already would have done it. And so I know that we're data-driven, and of course this is just a result from one study. So we certainly can't generalize this from one case, from one veteran. But I think these results are cool, and they were exciting to me. So this is a valued living questionnaire, which is my favorite measure of engagement with values, and it shows that his behavior really changed in the context of treatment. So he really by like about 40 points engaged differently with his values, and so he was able to kind of open up to new areas of importance, but his behavior really directly changed. And so what I did here is I kind of included some quotes from the Narrative Evaluation of Intervention interview, the NEII, that I thought nicely mapped on to his change in engagement with his values. Here he said, "I think the biggest thing I did during the intervention that helped was trying to accept the fact that I can value something without living up to that value, that it's more about moving in the right direction than it is about being or not being any particular thing." So this really, I think that illustrates engagement and values, but also his psychological flexibility related to those values. And then these kind of get at two different processes related to ACT that are important. Experiential avoidance, so this is the acceptance and action questionnaire, and cognitive fusion. So you'll notice that these scores continued to decrease into 1 month follow-up, and I'll share these examples get at kind of willingness to feel moral pain. With the focus of this intervention being acceptance of moral pain, it helped me to make peace with the fact that I will feel moral pain based on my moral injuries, and that's okay. It's a good thing to feel pain and mourn the loss of life. That does not make me weak or less human or anything else. It means that I am human, that I'm able to feel. This next quote kind of illustrates this as well. He said, well, this intervention didn't make it so that I no longer feel pain. What it did, it made it so that I could connect with that pain, so that I could interact with it with more responsibility. And it helped me to identify with areas that I connect to and be able to accept that in life I will always feel a lot of moral pain. And I'm still able to accept happiness or I'm still able to feel happiness and feel connected to others. These are kind of just a sort of summary of the results here. I think really this is a nice example of moving towards new valued areas while carrying moral pain, while carrying these stories about you, and in moving towards new values, kind of writing new stories about who it is you want to be, what you want to stand for, what you want to become. He became less stuck inside of his suicidal thoughts during our work together. However, future studies are really needed to look at this in a larger sample. He spontaneously identified on the NEII, he compared ACT-MI to cognitive processing therapy, and I think this is interesting, so I'm going to share it. He said, the biggest difference between ACT-MI and CPT is that ACT is focused specifically on the idea that I need to accept what has happened and not so much try to reassign blame for it. with many other treatment modalities, it is focused on aiding victims and survivors to reassign blame and guilt for what they had been through. In my situation, I had been unable to do so because the facts of the matter are that I bear full responsibility for the deaths of many people. So he's really stuck in that. This treatment was very effective in helping me to develop my values so that I can feel pain without being consumed by it, and also focus on striving towards living up to my values and accepting where I am now instead of comparing myself to where I was or where I want to be. So to be cognizant of our time, I'll just spend a second on this, but this is the next slide I'm going to show you is the aims related to our acceptability and feasibility trial for ACT for Moral Injury. So our aim is to determine the acceptability of ACT for Moral Injury and present-centered therapy for 72 veterans, endorsing impairment in functioning associated with moral injury. We didn't make this an efficacy aim because we're still developing the intervention and we're not powered to do so with this number of veterans. So we really just want to know, how do veterans find these treatments? What do they think? What's their experience like? Are they willing to kind of continue and engage in them? And are they feasible to implement in the VA? And feasibility gets at recruitment, it gets at fidelity to treatment, participant completement of the intervention, completement of study procedures, and this will help us set us up for our efficacy trial. As will evaluating candidate measures of functional outcomes, ACT-related processes, and symptoms of psychopathology. So this will help us kind of understand which measures might be most sensitive to change in a future RCT. And then this just references our design. So we're including really most veterans who have been deployed to a war zone and identify difficulties in functioning related to morally injurious event exposure and are, of course, willing to be randomized to either intervention. We're only excluding veterans who really demonstrate kind of treatment interfering symptoms of like substance use. So for instance, or psychosis or mania, like you're so acutely using substances that you can't come to a therapy group or engage in homework related to that. So I will open it up for questions now. Thank you all very much.
Thank you so much. So we do have a few questions that have come in. I know people joined us after the top of the hour, so to submit your question or comment, please use the GoToWebinar control panel located on the right-hand side of your screen. Down towards the bottom, you'll see a question section. Just click the arrow next to the word questions. That will expand the dialog box, and you can then submit your question or comment there. And the first one came in. Can you please explain what you meant by, quote, bold move?
Oh yeah, that's a great question, and I realize I take for granted some of the language I use sometimes. So thank you very much, whoever asked that question. So a bold move is really an example of a committed action and act. So what that means is it's a behavior that the veteran determines to be values consistent, that'll move them in the direction of a value that they care about. And we usually do a lot of work together to break up potential behaviors into really small kind of doable steps that are consistent with values. So for instance, an example of this might be if my value was to re-engage in spirituality, a bold move might look like, this would be a bigger bold move, holding a Bible. Or if that's, your spiritual orientation, or if my value is to, start to engage in a different kind of relationship with my children where I'm actually present, a bold move actually for this service member that I referenced, a bold move would be having his daughters kind of determine what they're going to do to play together and using all of his mindfulness skills to really be present despite what his mind is doing in relation to playing with his daughters, because playing with his daughters evoked a lot of pain for him because he had to take the lives of children. So beautiful question. That's what a bold move is.
Thank you. Several people have written in thanking you for this excellent presentation, so I wanted to get that out there. What differentiates ACT for moral injury from ACT trans diagnostic approach generally?
Yeah, that's a beautiful question too. So I would say, really the goal of ACT in general is to kind of be functional about what's happening in the moment, so to kind of help our veterans notice the function of their behavior and how it's potentially interfering with their values, and to move towards their values while they're experiencing whatever they're experiencing. So in that way, there's no difference, right? But there are some real differences, I think. The main difference is that we're focused specifically on moral pain pain related to the morally injurious events that these individuals have experienced. So it tends to be a lot more focused on shame and guilt. I mean, it really depends on the composition of the group, though. Sometimes we have a group that's kind of experienced more other directed morally injurious events, so might be about cultivating more flexibility in relation to anger. I think one thing that Jake Farnsworth and I have noticed in our work together is certainly, you know, all ACT applications are focused on self as context. We do a lot of work practicing kind of holding stories about ourselves for what they are, holding stories lightly, and moving towards what you care about. And I think oftentimes that can include more valued engagement related to self-care and spirituality and different kinds of engaging in relationships that you know, the content might look a little bit different in like kind of a standard transdiagnostic application of ACT, but I would say really the explicit focus on moving towards these things while you're carrying moral pain. And I think just the content, the topography of what the veterans and service members describe associated with their experiences has to do oftentimes with war and with the impacts of things like killing and that related content. So more focused on moving with moral pain and what that looks like. So more stuff to try and elicit shame and guilt and to try and kind of like slow down and relate to that flexibly in the room, and more values engagement that might take people kind of into those experiences, right? Because if I've avoided engaging in spirituality because of shame, engaging in spirituality is going to evoke shame for me, and noticing that experience. So I would just say those things shift a little bit, and really the focus on storytelling, I think, is different in this approach.
Thank you. So for the next question, can you discuss the pros and cons that your team reviewed before deciding to move forward the ACT-MI as a group intervention? The potential benefits of doing it in groups are obvious. However, I would imagine that shame is a major barrier for vets with moral injury engaging in a group treatment.
That is a really beautiful question. Also, you guys are asking very thoughtful questions. This is a conversation that Jake and I still continue to have, and Robin and Kent as well. I think so far we have seen, and of course this is an acceptability and feasibility study, we could decide down the line that like individual applications are more appropriate. I think it's more idiographic than that. I think it probably depends on the veteran or service member. But we thought, I mean, part of this work is really, and I haven't really talked about this, in not challenging the content of your moral injury related experiences. I'm not positioning myself as a moral authority, right? I'm not saying kind of what's right or wrong. It's up to you and your experience. And I think it's important with that in mind to have veterans have the opportunity to kind of understand what moral pain looks like with other veterans and other service members who've been through similar experiences, to elicit and evoke and engage those experiences. I think it's a great thing to have two facilitators doing this intervention, because, you know, if I miss something, my co-facilitator will catch it. If he misses something, I'll hopefully catch it, and I'll be able to do more in kind of trying to activate different processes for different group members in the room. I think just like in the, you know, literature on cognitive processing therapy and prolonged exposure, it's an empirical question whether or not a group is kind of the optimal setting for this. We really felt like a group fit with our theoretical justification for ACT for moral injury and social functionalism. So we thought we might get more bang for our buck that way in terms of kind of eliciting more salient experiences for people. We have people do pretty intense experiential exercises in the context of the group together, and that's, I think, been helpful. And also, I think another facet of a group is creating kind of a new social context and a new opportunity to practice engaging with moral pain differently within that context. I think, of course, like those are all the pros. The cons are that we're potentially not getting at like a specific individual's flexibility related to their moral pain and engaging their values sufficiently because we're focused on so many different people. But our groups are pretty small, so they tend to be about four to six veterans a group. The way that we have proposed the grant, an ideal number is about 6 veterans a group, so hopefully small enough that we'll still have the opportunity to stay as focused as possible on each person's experience.
Thank you. We do have several pending questions. Are you able to stay on for a few minutes so we can get those in
Yeah,
the
I think
recording?
so.
Excellent. Okay, so for any of our attendees that do need to drop off because it's the top of the hour, this has been recorded and you will receive a follow-up email with a link leading directly to the recording. So if your question hasn't been answered yet, it will be in the recording, so you will have access to it. And if you do exit the session, please wait for just a second while the feedback survey populates on your screen, and take just a moment to fill out those few questions. We do look at your responses carefully, and it helps us improve the presentation as well as the program as a whole.
And I will say
question.
you can.
Go ahead.
Oh, sorry. I'll just say you can for sure email me if you have to go, and I'll do my best to respond to those as soon as I can.
Thank you. We appreciate you making yourself available after the fact. The next question that came in, you mentioned you are currently running studies to see which ingredients of the treatment are critical and key. How are you able to see that from the results?
Oh, so I would say so far it's just been based on veteran feedback. So we're very much in it. That's another great question. We're very much in a place where we're just like looking on kind of like what pieces of this seem to resonate. One of the cool things that we'll have the opportunity to do in the grant is we'll be audio recording, and actually we might even move to video recording, although that hasn't been IRB approved yet. We'll be audio recording our session so that we can have ACT experts, Robin Walzer and Kent Drescher, review our tapes and really kind of identify what processes are happening. I think that's one piece we're kind of attending to. The other piece is more related to measurement. So I think I referenced that, you know, there's a lot of debate about kind of how we measure moral injury and the most meaningful ways to do that. One of the things our team is really trying to attend to, like you said in the question, are the processes that keep people stuck in moral injury and the processes that our intervention is eliciting. So one of the things we're piloting for the grant is using an application that we've developed with an app developer to look at, to use ecological momentary assessment so we can see how veterans are engaging their values and experiencing moral pain both pre and post-treatment for about a week. And I think that'll give us a sense of, too, kind of what's going on in the moment. So instead of just doing only pre and post measures like you would see in a typical study, the EMA periods, excuse me, are for about a week, where we'll be pinging veterans to respond on their iPhones, on their personal devices 3 times a day to questions from an item pool that contain questions about values, questions about experiential avoidance, questions about kind of different emotions that they're experiencing to kind of help us even understand that further. But I think the audio recording and potentially even video recording, so we can detect social cues that veterans are putting out there in response to Jake and I facilitating the group will be really important, because again, these emotions are very much social about relationships.
Thank you. The next question, have you tried this with non-combat female veterans suffering from sexual trauma?
I have not. I have worked with non-combat female veterans suffering from sexual trauma, but have used prolonged exposure and other interventions. So I think that is a great question, or not question. Well, it is a question. I think that's an area that we have not moved into. I think it'd be really interesting, and to kind of see what would emerge in the context of that. And I should say, most of the research is really focused for moral injury on war zone veterans. I know that like Matt Gray's team at the University of Wyoming is, I think they've worked on a scale of exposure to morally injurious events for civilians. So there is certainly talk about this in the literature, but this is moral injury itself. It certainly isn't new, right? I mean, this stuff was talked about in the Iliad by Homer, but I think it's new to our field. So yeah, my work in this has been limited to war zone veterans, unfortunately, and fortunately, to get kind of specific related to that. But definitely more work needed.
Thank you. The next question, what is the best way to get access to the ACT-MI manual when it is completed?
So the best way is to email me in a couple of years, and I know that's kind of an annoying response. So hopefully, so there are a few things. I would certainly refer you to, we have several publications that I referenced in the references. Let's see, these Farnsworth publications, oh, nope, that's our manual, sorry. there should be, yep, a 2017 publication kind of explains in more detail our approach and gets at the conceptual model that I identified earlier. There's also a cool paper that was published in 2015 by one of our collaborators, Jason Nusma. I don't think I referenced that one in here, but let me know if you're having trouble finding that. This pilot study will go on for about 3 years. So once the study is concluded, we'll have a working version of our manual that I can certainly distribute. And then the next step for us will be applying for funding for an RCT for a randomized controlled trial. So I think in a couple years, if you're willing to bear with me, we can provide the manual to you. But in the meantime, those papers and that case study I shared, I submitted for publication. It's under review right now, so we'll see what happens with that. But hopefully that'll be out for the public soon as well. And you can certainly email me and just let me know you're interested, and we can try to keep a list, or try emailing me in a little bit. I'm sorry that this is something we can't provide immediately, but we're still working to figure out what components of the intervention are helpful, are most critical, if it's even acceptable and feasible, and then at that point we can kind of really drill down and be able to distribute it.
Thank you. The next question. Well, that's the same one. They want to know where they can access it. Sit tight for a little bit. What differentiates ACT for moral injury from ACT oh, I think we did this one. ACT transdiagnostic. Okay, yeah, we did. Okay. In the scope, do you use, quote, eyes on?
So I have used eyes on. We don't typically use it in our group right now, but I have done it in other groups before. I think it can be incredibly intense and powerful, but no, that's not one that I've used recently. It might be one that could be better in an individual context too.
Thank you. Just 2 more questions. In the scope of DSM-5, how is the clinician, it's old habit, how is the clinician to define moral injury, or how is the clinician to define moral injury? Is this actually a cluster, a personality disorder?
Yeah, so I think that's a really good question. I think there is a lot of debate in the literature. I would argue that we're not advocating for a diagnosis for this. I think diagnosing moral injury pathologizes healthy and appropriate responses to moral pain, kind of trying to reduce symptoms of that per se. What we're trying to do is move people towards their values while experiencing moral pain. I also, and I'll step off this soapbox for a second, I think there are a number of problems with the DSM, and at the same time it's all we have, but there's so much heterogeneity even within the diagnosis of PTSD that, like, what really does it mean? And it's important. I'm certainly not saying that it's not an important or useful tool that we have. So I can tell you a little bit about how we are working in our work group to identify people for the grant, which I think speaks to this, and then I'll kind of speak a little bit to future directions. There is actually, if you're interested in seeing kind of what Brett Litz's team is doing, they have a consortium. I can't remember the name of it, all of a couple of different sites in the country and then a couple different sites internationally to really kind of define the boundaries of moral injury, and part of that is figuring out, like, what is this? Is it a syndrome? Should this be a diagnosis? Like, what does this kind of mean? So that work is ongoing, which I think is really unique about developing an intervention for something that we're still working to kind of understand and characterize. If you want to reference papers related to that, Julie Yetarian, I probably said her last name wrong, I apologize if I did, published a paper recently. There's a special issue in Journal of Traumatic Stress that gets at moral injury, and they published a paper on kind of their first phase, qualitative phase of assessment development related to moral injury. So that's a cool resource to check out. As far as what our team's been doing, we're really interested in functioning related to moral pain, right? So, like, how relating to these experiences is causing you to stay stuck and causing you to suffer. So the way that we're assessing this is we're having all of our participants fill out the moral injury questionnaire and the moral injury events scale. Both of those are scales that get at exposure to morally injurious events. And then we're asking them, like, in response to these events, like, how has this affected your functioning? How has it affected your functioning in relationships? Has it affected your functioning spiritually? How has it affected your functioning related to self-care, right? How has it affected your your functioning overall, and if it has directly affected your functioning, do you think this is something like you're struggling with? So it's more of an interview that we've developed to really characterize what moral injury is. I would not call it a personality disorder or something that we can characterize in the DSM-5. So I think that's a really nice question that gets at some of our kind of areas of research and future development.
Thank you. And the last one is just a comment. This is an excellent extension of NIH's study Forwarding Grief for Complicated Trauma and PTSD, which I participated in. So thank you for your presentation and information. You are very accurate in assessment. So thank you for that comment. And with that, I would like to give you the opportunity to make any concluding comments that you'd like to.
Well, thank you all for taking the time to be here with me today. Hopefully you'll hear from me more in the future. Our group tends to present a lot, kind of given the scope of our interests at the Association for Contextual Behavioral Science. If you're ever interested in going to ACBS, it's in Ireland this year, so that'll be a cool experience. New Orleans next year, so definitely more local. But yeah, it's been a blast talking to you all today, and definitely stay in touch if you have questions.
Excellent. Well, thank you so much for coming on and lending your expertise to the field, especially on this important topic. And thank you to our attendees for joining us. I am going to close out the session in just a moment. As a quick plug, we are having the third class of our suicide prevention course taking place this Thursday at 3 p.m. Eastern. It is also accredited, so you can go to our registration catalog and sign up for that if you would like to. Otherwise, we run our suicide prevention sessions every other month on the second Tuesday at 3 p.m. Eastern. So with that, I'm going to close out the session, and for our attendees, please stick around and fill out the feedback survey that's going to populate on your screen. Thank you once again, Lauren. Thank you, everyone. Have a great rest of the day.